Hello guys, I am really sorry for the delay because of some personal reasons I couldn't upload the video for the past few days. So now we are back with the gastrointestinal pathology section 3, page number 387 of USMLE First Aid Step 1 2022, page number 387. So now let's quickly go on to the annotation. So here we have written systemic sclerosis. We have got Crest syndrome and systemic sclerosis, right? We have got calcinosis cutis, Raynaud's phenomenon, esophageal dysmotility, then scleroderma and telangiectasia. These are the Crest syndrome that is seen in systemic sclerosis. Here, what is the antibody happening? Here the antibody is against centromere protein. Centromere protein antibody is seen. So here the topic is Barrett's esophagus. Many questions are associated with Barrett's esophagus. Here we have summarized it, and what is it? Here we have to write acid mucin in goblet cell can be stained by Alcian blue. Acid mucin in the goblet cells can be stained by Alcian blue. Just quickly, what happens in Barrett's esophagus? We have got squamous cells in the esophagus, and we have got columnar cells in the with columnar cells with goblet cells in the stomach, and therefore because of this GERD, chronic gastritis, what happens is this squamo-columnar junction, this one squamous, this one is columnar, squamo-columnar junction located here comes up, which means esophagus will be taken over by the goblet cell containing columnar cells of the stomach. So the squamo-columnar junction or the Z line, it moves up in a Barrett's esophagus. What is the most common cancer associated with Barrett's esophagus? It is adenocarcinoma. Adenocarcinoma is the most common cancer associated with Barrett's esophagus, whereas in achalasia cardia, where we have got the problem with Meinrich plexus in the lower end of esophagus, which fails to relax, increased lower esophageal sphincter pressure, that the carcinoma associated with that is squamous cell carcinoma, whereas in Barrett's esophagus it is adenocarcinoma. Don't get confused. Okay, then now we go on to esophageal cancer. Here we know that I saw one question where esophageal cancer, it is rapidly extending. Why this rapid extension? What allows this rapid extension? It is the lack of serosa in the esophageal wall. When one component of our esophageal wall is deficient, it makes it very easy for the cancer cells to go on. Therefore, lack of serosa in the esophageal wall makes it easy for the esophageal cancer for a rapid extension. Then so squamous cell carcinoma is in the upper 2/3 and adenocarcinoma is in the lower 1/3 of the esophagus. Lower 1/3 adenocarcinoma, it occurs due to, now we know that it is due to Barrett's and also GERD. Squamous cell carcinoma is associated with achalasia cardia. Okay, then recent AIMS question, in the esophagus, in the middle 1/3, you are seeing an exophytic growth. Okay, exophytic growth, and there is also apple core appearance of the growth in the middle 1/3 of esophagus. What is that? If you see that it is in the middle 1/3 of esophagus, when you check in with this, which one is getting included in it? It could probably be in the squamous cell carcinoma category because it involves the upper 2/3, right? So middle 1/3 comes under this upper 2/3. It is probably squamous cell carcinoma. Now we also know that it is an exophytic growth, apple core appearance, and we also see keratin pearls in them. So there was a histology showing keratin pearls. Therefore, it is most probably squamous cell carcinoma. Then we go on to this recent NEET question. We have got an old female with upper GI bleed, and she is also febrile. When we inserted a nasogastric tube, we could see that blood was coming out. CRP of the patient was 23. And what upper GI endoscopy, when we did the endoscopy, we saw extensive gastric ulcer with necrotic tissue and edema in the mucosa. In the CT, we show a thick gastric wall. What is the cause of this condition? That was a quite unfamiliar question for me. So this one alarms us. No, when we see that in the upper GI endoscopy, we are seeing extensive gastric ulcer with necrotic tissue. Necrotic tissue alarms us, means the cells are getting dead. It has become necrosed. So tissues in the stomach mucosa has become necrosed. Therefore, it is an emergency condition. Okay, what is the condition caused by? The cause of the condition is E. coli, and the condition is known as phlegmonas gastritis due to due to E. coli. Okay, it is a life-threatening condition. Diffuse acute infiltrate inflammatory infiltrates on entire gastric wall with necrosis. This alarms us. Immunocompromised people, elderly people. How did this lady become immunocompromised? She is an elderly. Okay, she is an elderly person. If it is a diabetic or another cancer or anything like that, she becomes immunocompromised. So now here it is an elderly person. So what are the bacteria, the organisms causing this phlegmonous gastritis? The organism, one we have seen, it is E. coli. Others are Streptococcus, Staphylococcus, Proteus and Haemophilus are other bacteria that can cause this phlegmonous gastritis. Okay, then ranula, just an addition. Ranula is a mucus extravasation cyst, most commonly seen in the sublingual gland. It is transluminant mucosal. When you shine a torch, it is going to be brilliantly transluminant. Then fluid is retained inside now, so fluctuation test is positive. Then it is also called as a frog's belly because it looks like a frog's belly, no? And it is conservatively managed by marsupialization. We do that conservative management of marsupialization. Definitive management is excision of the cyst. When do we call it a plunging ranula? What is called as a plunging ranula? Plunging ranula is a mucus retention cyst from the sublingual gland. Mucus, how does that go? From the sublingual gland it goes to the neck, so the swelling is in the neck. How did that go to the neck? Mucus through the mylohyoid muscle, it went to enter the neck. Intraoral and cervical swelling can be seen. Diagnosis is by USG and MRI. Management is by excision of the swelling plus aspiration of the saliva out. Okay, so this is the management of ranula. Now we go on to the next page, that is 388. So here what we have is a recent NEET question. Antral biopsy for H. pylori ulcers. Okay, in H. pylori ulcers, what biopsy are we? Which part of the stomach are we going to biopsy? It is antral biopsy. So chronic gastritis, we have got two types of chronic gastritis. One is H. pylori associated gastritis and autoimmune gastritis. Here this autoimmune gastritis starts with A, no, therefore it is type A gastritis. H. pylori is a bacteria, no, so it is type B gastritis. H. pylori is the most common one. It is associated with marked lymphoma. It can cause hypergastrinemia. It affects antrum first and spreads to the body of the stomach. Why? Because we have got hypergastrinemia in this H. pylori associated gastritis. There is lot of what happening. We have got lots of acid getting produced. It affects the antrum first and then spreads to the body of the stomach, and then finally all this acid will be released to the duodenum, where the person will have duodenal ulcers. Okay, in the first part of duodenum the person might have ulcers. Then about type A gastritis, it's autoimmune. To what? It means some antibody, some autoantibody is being produced. So against which poor bechara tissue of our body is this antibody getting produced? It is against parietal cells and to intrinsic factor autoantibodies are being produced. Autoantibodies to the H potassium ATPase on the parietal cells and to intrinsic factor, and there is increased risk of what? Pernicious anemia. Why? Because parietal cells produce HCl and intrinsic factor, and because of this intrinsic factor deficiency we are going to have this pernicious anemia. Okay, and this one autoimmune, it affects the body and fundus of stomach and it spares the antrum. Whereas in H. pylori thing, we have got the antrum getting affected first. Whereas in the autoimmune thing, we have got it is sparing the antrum. It's quite opposite, no? In autoimmune, we have got A, antrum is spared. Whereas in H. pylori, it starts with H, but it is antrum that is affected first. Okay. Then about Mentrius disease, we have got nothing to annotate. I didn't get anything to annotate. Most commonly this gastric adenocarcinoma is seen at gastric adenocarcinoma, the most commonly located at antrum. Okay, gastric adenocarcinoma is most commonly seen at antrum. Then what else? Gastric adenocarcinoma, you are going to see signet ring cells, no? Signet ring cells. Then what else? See, this is the signet ring cells. It looks like a ring. Okay, this one is called as, with the nucleus pushed to the periphery, it looks like a ring called as signet ring cells. What about most common site of CA stomach? Most common site of CA stomach is at the proximal stomach. Proximal stomach. CA stomach in pernicious anemia, most commonly located at the fundus. Fundus. Diffuse variety of carcinoma stomach is located at the fundus. Pernicious anemia wala CA stomach and diffuse variety of CA stomach, both of them are located at fundus, whereas most common site of CA stomach is proximal stomach only. Gastric lymphoma, if you see gastric lymphoma, it most commonly involves the antrum. Burkitt's lymphoma or Epstein-Barr virus lymphoma, it is going to affect the cardia and body of the stomach. Just note them down. Then another important topic, originally located in surgery. Now we are just brushing over the Borman's classification of gastric cancer. Okay, type 1 is a polyp-like thing, polypoidal, fungating. Type 2, we have got, instead of this polyp, you have got an ulcer. It could be a fungating or an ulcerated one with surrounding elevated borders. See, we have got elevated borders. It is an ulcerated lesion. It could also be fungating. Type 3, the ulcerated lesions infiltrating the gastric wall. It is an ulcerating lesion, but it has infiltrated the gastric wall getting infiltrated. Then this one was asked in the recent NEET. Type 4 is also called as linitis plastica. It is diffusely infiltrated. The gastric wall is completely diffusely infiltrated. Type 5 is unable to be classified. Whatever cannot be classified under the above 4, you can put it in type 5. Okay, then the next portion, page number 389, come to acute GI bleeding. And what is this? This one is suspensory ligament of duodenum that connects the duodenojejunal flexure, okay, to the right crus of diaphragm. Then we have got a recent NEET question. Most common site of branchial cyst is at the junction of upper and middle 1/3 of sternocleidomastoid muscle. Junction of upper and middle 1/3 of sternocleidomastoid muscle at the anterior border. In the anterior border at the upper and middle 1/3 of sternocleidomastoid muscle. And what is this branchial cyst? It's actually a second brachial cleft cyst. Okay, it contains what? It contains cholesterol crystals. Then what about branchial fistula? It is a congenital fistula at the junction of middle and lower 1/3 of sternocleidomastoid muscle. We have already talked about something that is related to the upper and middle 1/3 of the sternocleidomastoid muscle. What is that? That is the branchial cyst. Now we come on to the next topic, that is branchial fistula. It has got a channel that is connecting. So it is located between the middle 1/3 and the lower 1/3 of the sternocleidomastoid muscle. This one, that is branchial cyst, was located in the anterior border. Okay. Then what about parotid surgery? In parotid surgery, the most commonly injured nerve is which one? It is a greater auricular nerve. So parotid surgery is located in front of the ear. So it is greater auricular nerve. So I mean the parotid gland. Okay. Most commonly injured nerve is a greater auricular nerve. In Frey syndrome, the most commonly injured nerve is which one? Frey syndrome. Frey syndrome, it is auriculotemporal nerve. Greater auricular nerve. Parotid surgery is a bigger surgery. It is done in the major OT. So we have got a greater auricular nerve getting involved. Frey syndrome is just something, it is that sweating happening, therefore it is most common, it is a minor thing, no? So it is not greater, we have just auriculotemporal nerve. It's not greater. The greater one is parotid surgery done in the main OT like that. Auriculotemporal nerve is V3. Okay. Then V3, I mean 5, third branch of 5th. Okay, then mucoepidermoid carcinoma is the most common malignant tumor. Then pleomorphic adenoma is the most common benign tumor of parotid. So considering the tumors of parotid, mucoepidermoid carcinoma is the most common malignant tumor and pleomorphic adenoma is a benign tumor. Okay, then what else? Facial asymmetry, lump on the roof of mouth. Think of a lump on the roof of mouth and swelling with diffuse borders. And on biopsy you are seeing Swiss cheese pattern. Okay, what is the diagnosis? It's an adenoid cystic carcinoma which has got the best prognosis. Okay, adenoid cystic carcinoma which has got the best prognosis. So it is mucoepidermoid carcinoma, that is the most common malignant tumor, pleomorphic adenoma being the most common benign tumor of the parotid. If you see a person with facial asymmetry because of the perineural invasion to the facial nerve and lump on the roof of mouth and the swelling with diffuse borders, and on biopsy you are seeing a cheese-like pattern. So this cheese pattern, the diagnosis is adenoid cystic carcinoma which has got a best prognosis. So dear friends, that's all for today.